Good morning, everyone, and welcome to our International Colorectal web meeting. Today we have participants from Bangladesh, Ukraine, Egypt, Spain, India, United Kingdom, South Africa, Turkey, Mexico, Thailand, Saudi Arabia, Malaysia, Indonesia, Libya, and United States. If I did not mention your country, just type in the chat. We will acknowledge at the end. So the first case will be presented by Dr. Carla Santos from Mexico. And just remember, if you're not speaking, please turn off your microphone. Welcome, Carla.
Good morning, Andrea. One moment, please. Good morning. Today, I will present the case of a boy who was 3 years old at the time of the initial consult. He had diagnosis of Hirschsprung disease. At the birth, the patient had abdominal distension. He could not pass meconium for the first 48 hours, and he had poor tolerance to oral feeding. The patients underwent a transanal pull-through without a prior rectal biopsy at another hospital. After the surgery, the patient had sepsis with pneumonia, and he stayed in intensive care for more than a month. And finally, at 2 months of life, the surgeon performed a laparotomy with appendectomy and constructed an ileostomy of 2 stomata. The postoperative diagnosis was rectal stenosis at the site of the previous colorectal anastomosis. The patient was sent to us because of severe and persistent rectal bleeding. In this country, they performed a distal ileostogram in which we observe colitis, white speculations of irregular walls, and at the pelvis we observe stenosis, but we don't have more image to show. In this contrast cinema, we can appreciate the rectal stenosis. The study still showed signs of colitis. Blood tests show hemoglobin of 6.5 GR, hematocrit 22, leukocytes 14,200, coagulation times were within normal limits, and iron and ferritin had very low values. What would you do next? The first option is closure of ileostomy. The option 2 is rectal irrigation with or without metronidazole plus iron and folic acid supplementation. Option 3 is rectal exam under anesthesia with rectal biopsy. 4, iron IM and rectal irrigations with metronidazole. And the last, colonoscopy and consult with pediatric GI, rule out inflammatory bowel disease. The majority of people say rectal exam under anesthesia with rectal biopsy. The patient was evaluated in his country by a pediatric GA to rule out inflammatory bowel disease. The endoscopy showed severe colitis. He had a positive calprotectin study as the only marker for inflammatory bowel disease. He received rectal irrigations with saline with metronidazole plus iron AM and PO, folic acid, and rectal mesalazine. After months of rectal irrigations, we repeat the contrast enema and we observe improvement in the colitis. The rectal bleeding resolved, and he maintained a better hemoglobin level. We performed a prostatectomy resecting the rectal stenosis by means of transanal full thickness and abdominal approach. In the first image, you can see the preserved pectinated line. We took a biopsy about the rectal stenosis through the abdomen, which was normal ganglion. You can see the appendix. Maybe they did an incomplete appendectomy in the previous surgery. We perform a pull-through of the descending colon with colorectal anastomosis with simple sutures. In the second image, you can see the preserver, the pectinated line. The final report of histopathology was that the distal margin showed hypertrophic nerve trunks and some submucosal plexus without ganglion cells, but all mesenteric plexus with ganglion cells. The proximal margin was normoganglionic in both plexus, and ileostomy stomata were normoganglionic. Discussion. The current age is 4 years old. He began fecal sphincter control. He has 2 bowel movements per day. He has constipation and he takes Senna, 8.6 milligrams QD. And the X-ray control after fecal evacuation is here. He received dilation of colorectal anastomosis with number 15 Hagar. He doesn't have rectal bleeding. And our last comment is focus of colitis due to intestinal diversion that some patients present. The literature says that they are related to the lack of medium chain fatty acid that are forming bacterial fermentation and certainly to local bacterial translocation. That's all. Thank you very much.
Thank you very much, Carla. I find very interesting that the surgeon said they did an appendectomy and you found the appendix. And I think I learned from Dr. Peña to always be skeptical about operative report, because sometimes the operative report describe what the surgeon thought they did. And when we operate on the patient, we find something completely different. So I think this patient suffered a surgical complication. He obviously had a severe stricture. I'm not sure if, I have never seen a case of severe bleeding like that. And when we had cases of diversion colitis, the pathologist said they could not differentiate diversion colitis from enterocolitis in a patient with Hirschsprung. I think in your case, what it is impressive is the amount of bleeding. And I don't know what is the true origin of that. But congratulations on the results, on taking the challenging and operating and the excellent outcome that in reoperations, it does not always happen. So this patient has voluntary bowel movements, which is very good. Do you have any comments? Any questions or comments from the audience? There is a question, is there any relation of Hirschsprung disease with inflammatory bowel disease? I have never seen a case of Hirschsprung disease and inflammatory bowel disease. Carla, Luis, Alejandro, anyone has ever seen a case? No. Yeah, we have never seen. I don't think it's impossible to happen, but it's probably extremely rare. Thank you very much, Dr. Santos, and we're gonna move to the next case that will be presented by Dr. Carolina Giraldo, who is Dr. Carla Santos' fellow. Welcome, Dr. Giraldo.
Good morning. Today I will present the case of a boy who was 16 years old at the time of the initial consult in the colorectal clinic. He had constipation since 6 months old. Currently, he was sent to our service by fecal infection. The past medical history showed multiple visits to the emergency department because of fecal infection, but he did not have appropriate follow-up. The gastrointestinal clinic treated him with polyethylene glycol and enemas. His mother was a teenager when he was born and had mental retardation and communication issues. This is his initial X-ray that showed a real fecal infection. The patient, he looks pale, malnourished, and with great abdominal distension. After many irrigation and enemas with very low volume, approximately 200 milliliters, we showed the following X-ray. At admission at the hospital, the evaluation by mental health made the diagnosis of generalized anxiety disorder and attention deficit hyperactivity disorder. He had a manometry with inhibitory rectal reflex present, preserved rectal sensitivity, hypotension, and decreased rectal contractility, with findings of anal tone not recovered after testing for inhibitory rectal reflex. So he had an MRI of his spinal lumbar column that was normal. The patient didn't have tether cord cone ends at lumbar 1. We can see here the colon enema after many irrigation until fecal disinfection. With the aforementioned background, what will you do next? Fecal disinfection with irrigation, fecal disinfection at operating room, fecal disinfection at operating room and rectal biopsy, rectal enemas followed by bowel management program, I don't know. So the majority respond fecal disinfection and rectal biopsy. Okay, that's what we do. We perform a fecal disinfection and rectal biopsy. That was a ganglionic. So we must confess that we did not expect this result and we say we had a big problem. We performed a protectomy initially by transanal approach. In the first image, you can see the pectinate line that we hide with the separators. We place a line of silk sutures to initiate traction when performing the protectomy. It was difficult because of so much perirectal inflammation. After 12 centimeters of the dissection, perirectal, we decided to send to the intraoperative biopsy of the rectum, that was a ganglionic. We can see here in this image the submucosal aganglionic plexus. By abdominal approach, we perform a dissection of the sigmoid. We sent a new colonic biopsy and it was normoganglionic. We decided pull-through of the descending column above the great rectal and sigmoid dilation. You can see here the left ureter and the sutures of the ligators of the vessels of the mesorectum and the mesocolon. This is the final aspect of the colorectal anastomosis. This was the megarectum and megasigmoid. We didn't have protectomy stomach, so we have to leave the Jackson-Pratt drain. But 4 days after pull-through, the patient had fecal evacuation through the drain. The X-ray showed intra-abdominal free air, so we decided to perform an ileostomy of 2 stomachs. At the laparotomy, we observe a clean pelvic cavity with no output of fecal matter, so we do not review the anastomosis and transanal view. In the postoperative, was fine. He received a rectal dilation with Hegar 24. This is the distal ileogramma 4 months after the pull-through. We can see the rest of the colon with good permeability.
No leaks.
And with this image, we perform ileostomy closure with good evolution in the patient. Thank you.
Thank you very much, Dr. Giraldo. I think what happened in this case, the patient probably had an anastomotic leak, and that's why you saw stool in the drain, but then with the diversion, it healed on its own, and the patient did not need a reoperation. So I would say this is a fantastic case for being 16 years old with an undiagnosed Hirschsprung disease. We always say that Hirschsprung disease is a spectrum, and some patients with Hirschsprung disease, if they go undiagnosed, they die. And the patients that live with Hirschsprung disease are what we consider the benign, the good cases, the patients that don't have enterocolitis. And this is an example that mainly the patient had severe constipation. And congratulations on the result. I know, do you want to comment? No. Luis, Dr. De La Torre, do you want to comment?
No, thank you.
And I see there is some questions, but I don't, let me see.
It says, I had one case.
Okay. Perfect. Congratulations. This is a difficult case. The only thing that I think in retrospect, we can all argue, because that's the purpose of this meeting, is thinking how we can do better next case. With this massive dilation, I think I would have considered a diversion preoperatively, just because it was so dilated already that I think we would expect that the surgery will be difficult, the anastomosis will be difficult, the inflammation. That's the only consideration that I would put out there for such an important dilated colon. But congratulations. In our next case, we're moving very fast. We need more questions. So our next case is going to be presented by Dr. Sunny Yamut. Welcome.
Thank you, Dr. Bischoff and Dr. Pena, for the chance to present. I'm going to present a little girl that I'm taking care of, and I'm hoping to get some ideas about what to do for her. So we've not operated on her yet. We've just kind of been working her up. I'm working from only one screen, so I'm hoping I can, oh, here it is, okay. So essentially, this is a patient who basically had a Duhamel procedure and was left with probably the entire left colon as a spur. And we're trying to figure out what the best way to manage her is. So this is a 10-year-old girl who was being managed by the pediatric GI team for a few years. And then they contacted us because of acute onset worsening of a baseline vague abdominal symptoms. What's important about her is that she had presented at 7 weeks of age with right colon perforation, taken to the OR, underwent partial colon resection. And I say partial because it was difficult to determine from the operative note exactly which part of the colon was removed. short of the right side. We know that there was an ileal resection, cecal resection, there's no appendix, and then some degree of right colon resection with an ileostomy. I'm not going to go through the details of how this happened, but long story short, she was incorrectly diagnosed as having Hirschsprung's disease. So there was intraoperative suspicion of Hirschsprung's disease because of the right colon perforation. Got some biopsies. There were some mix-ups between the frozen section, sounds like, and the final diagnosis, and she was presumed to have Hirschsprung's disease. She came back at 9 months of age and underwent a Duhamel procedure. Again, vague abdominal note. There was some mention of resection of the colonic spur, but it was not very clear how much of the colon was removed. Now, going back to her symptoms, she's 10 years old now. She has baseline function of loose/watery bowel movements without any bowel management. She's not on any stool bulk formers or any stool softeners. Has around 3 to 4 bowel movements a day that are described as mushy, but again, occasionally watery. And sleeps in a pull-up mainly due to some urinary incontinence, which is not clear to me why she has that, but she does not have any stool incontinence. However, 2 months prior to presentation, she was having some worsening and more frequent vague abdominal pain, described as crampy, sometimes associated with eating and sometimes associated with nausea, but no clear pattern. And it's actually quite intermittent. So she'd have 2 or 3 days of being fine. And then she has this vague abdominal pain that's almost debilitating. She's nauseated, and then she gets better. So again, the GI team was working with her and trying to figure out what's wrong. And part of what their workup was getting a contrast enema probably 6 months before I saw her. And interestingly enough, the contrast, and this is just kind of the most important shot probably of the contrast enema, but this was read as contrast that fills around 30 centimeters of dilated small bowel. So when I was looking at her and I looked at this looked pretty much like it was a little difficult because when they did the contrast enema, they were not really looking at the Duhamel as a Duhamel, but from this shot, it pretty much looks like this is the ileal pull through down to the rectum. And then this is one long colon here. So again, I went back to the operative note, and there's no clear description of what happened exactly to the left colon. The only mention was that the spur was resected. So we figured, like, if you resected the entire left colon as a spur, there'd be a little more detail. Because it was not clear what the anatomy was, but we suspected that this was basically a retained left colon to some degree. We got a CT scan of her abdomen with rectal contrast, and I was there at this time for the CAT scan just to make sure we have all our questions answered. So she did not get any enteral contrast, only IV and rectal contrast. And basically this confirmed that here's her ileum that was pulled down into the Duhamel. The anastomosis is widely patent, and then she had a pretty long essentially segment of colon left behind. The colon was dilated, and the ileum upstream, I don't have good shots here, but the ileum upstream of the anastomosis, and where basically there was external compression on the ileum by this dilated colon. And there's no evidence of mechanical obstruction at the level of the anastomosis. So basically this patient had Duhamel where the anastomosis looks like it's working well, but probably has a combination of bacterial overgrowth in that very long segment of retained colon, and also partial kind of external compression on the ileum that is causing some obstructive symptoms. The main dilemma here is that even though this long segment of the colon that is retained is a liability because it's a very long retained spur, but it's normal. So this patient does not have Hirschsprung's disease. On review of her pathology, she doesn't have Hirschsprung disease. So short of being unused for the past 10 years and being dilated with a lot of bacterial overgrowth, this colon should, physiologically be normal. And that's the dilemma here, is that she has a Duhamel that looks like it's working well. She has 3 to 4 soft bowel movements a day, does not have any stool incontinence. So what do we do for her? Probably the simplest and safest option for her is to just optimize the Duhamel and go in and complete resecting the left colon and go down and transect this rectum flush with the anastomosis, so that we take out the component of bacterial overgrowth and external compression. But again, we're removing what looks like 30 centimeters of what was normal colon at some point. Or do we try to go for a home run and revise her anatomy and basically go down and disconnect this ileum, probably give her diverting ileostomy first, and figure out a way to address the defect that's left in her rectum, and then go back and hook up her ileum to whatever length of colon there is. And number one, hope this colon still functions. So even though it's dilated, it's not tremendously dilated at least by the imaging studies, probably because it was just stasis in there. So we'd have two problems. What do we expect? How do we expect this left colon to function, number one, and number two, how do we address the defect in the rectum? And also, we're going to be digging in the space that's reoperative and potentially while we try to get the best results for her, have a setback either from complications from this rectum, or end up with a colon that doesn't work, and now we connected an ileum to it. And these are the two things we've thought about so far as options, but also any other ideas would be greatly appreciated.
Thank you very much. I think this is a fascinating case. Unfortunately, we wish we could say it's extremely unusual for a patient to undergo surgery for Hirschsprung without having Hirschsprung. But I would say if you take into account the entire world, this is way more common than we all suspect. And in this case, the patient lost almost all her colon. So that is very impressive of this case. I'm going to give my opinion, and I'm curious to hear Dr. Peña's opinion and Luis' opinion. I think when I face those challenges, I think, okay, this patient already had the wrong operation once. I don't think she can afford more complication. So the ideal world would be, yes, to remove that ileum, incorporate and use that entire colon. That would be the ideal world. But in the real world, reoperations are extremely hard sometimes. You're gonna separate that ileum from an area that it's very close to the sphincter. So you're gonna put sutures immediately anterior to a competent and good sphincter. It's almost putting sutures on an obstruction. So the chances of having leak on those sutures are extremely high. And I think even when you say 30 centimeters from the contrast study, it looks to be a little less than that. I don't think it will make such a big positive difference in the life of this girl. From your report that she currently has 3 to 4 bowel movements a day and she's continent. So I think if I was facing this challenge, I would go for the easiest, most conservative approach that would offer less complications. So I would just remove the rest of this colon, but explain to the parents very well the rationale and document very well the rationale in your operative report and your informed consent. So that would be my opinion. I'm curious about Dr. Peña and Dr. De La Torre.
Yeah, I want to repeat something that I learned from a professor of mine that who used to say, if you are going to do an operation that is not indicated, you better do it right. So this girl had an operation that was not indicated and they didn't do it right. It's double mistake. But I want to go back a little bit and ask you, Dr. Yamud, what are the symptoms of the patient? The patient has bowel control. And what I missed that part. What is the problem that she has right now?
The problem that brought her back to our attention is this intermittent, vague, cramping, abdominal pain
cramping.
with nausea to the degree that she's debilitated. And that's one symptom that I couldn't perfectly, that's part of my concern also, is that I'm not clear how much this retained colon is contributing to her problem overall. Radiologically, it looks like it's partly pushing against that ileum, and the ileum is more dilated up to 5 centimeters upstream of that colon. But she does have symptoms that suggest some component of bacterial overgrowth, this cramping, severe abdominal pain that makes her nauseated. It's just not clear to me why it's intermittent, where she is fine for 3 days and has that severe discomfort once or twice a week. And that's my bigger dilemma, is I'm not clear how much of her symptoms of this vague, severe abdominal pain are going to get better with this colon resection. But I can only imagine how much bacterial overgrowth there is in that colon and hope that it will help her.
Well, the question also is, how is that colon working? Because according to your diagrams, that colon is not dilated. In a typical Duhamel, when people does Duhamel, they sometimes leave a little piece of that rectum and becomes dilated, becomes a pouch, is usually fecally impacted. And the colon that you are showing, I didn't understand well, but I think it's not dilated. That means that it's peristalsis. That's it. That diagram shows a non-dilated colon. See, so is that means that the peristalsis of that colon is normal, and so now I'm not sure.
Can I just?
I always have to apologize for my diagrams not being to scale. Sorry. Let me show you the animal.
Yeah.
You see, the colon doesn't look particularly dilated. You know, if I will go with the patient to the X-ray department, put contrast material in that colon, and then wait to see if the patient empties and how long does it take to empty the contrast material. If that colon has normal peristalsis, that colon has to be preserved, assuming that is normal ganglionic, that the patient doesn't have Hirschsprung. In other words, that colon has a function. And then the question is the separation of the small bowel from the posterior rectal wall. That, as Dr. Bishop said, sometimes is technically demanding. There will be two ways to do it. One is through the dilated anus, do like kind of a dissection through the lumen of the rectum, and then pull it from above. Another way to do it would be posterior sagittal. Posterior sagittal, I treated several of those patients, and you can separate the ileum. Is relatively easier to do, separate the ileum from the bowel, and close the posterior bowel wall. But I would not do with an protective stoma. I will not do that without a protection, because the posterior sagittal operations in patients with Hirschsprung or constipation should always be followed with a stoma, because we are leaving a suture in the posterior rectal wall in front of a normal sphincter that represents like a kind of obstruction. Oh, and then the question is, once you separate the small bowel, are you going to connect it to the colon, or you're going to do an ileostomy? I will do an ileostomy first, and then reevaluate the patient. And I still don't know exactly why the patient has chronic abdominal pain, but with an ileostomy, I would reevaluate the patient, I would reevaluate the function of that colon, and then the function of that small bowel, rule out all the conditions, biopsies, and then at the last step, connect the terminal ileum to that piece of colon, assuming demonstrated that that colon works well, which seems to be working well.
I think I had another idea of in the trying to be conservative, a test that you could do without surgical intervention would do enemas to clean that colon and just see if cleaning that colon makes that pain, nausea go away. If it does, then I think you have tested the hypothesis that the colon is the one possibly causing the problem. I think it's an option. Dr. De La Torre, do you have any suggestions?
Yes, I think the patient has so the main problem of this patient is the abdominal pain. First, this patient is a normal patient, is not a Hirschsprung patient. This should be clarified because there are many questions about this. So this patient is not a Hirschsprung patient. Is a patient that born without Hirschsprung. Number one. Number two, the current problem is not fecal incontinence, is not constipation, because the patient is presenting daily bowel movement and has fecal control. So the problem is the abdominal pain and the other symptoms. I also want to address the urinary incontinence, which is another problem for this patient. So number one, I will do a urodynamic study in this patient. I will ask to a neurologist to work with me and find out what is happening with the bladder, because after this bad operation, probably the patient has some damage of the innervation of the bladder. I don't know. Number two, I think the problem is, my advice will be, if the problem is the rectum, or it's not the rectum because it looks like rectum and sigmoid, you know, it's a super large pouch, but it's not dilated because it is a normal rectum. In other words, it has ganglion cells. So it has peristalsis. So in some point, I think the patient has peristalsis from the small bowel and peristalsis from the colon. That's why it's not dilated, and probably is part of the cause of this abdominal pain. To remove the rectum, and as you described, to cut or shorter the pouch, I think is a good idea. It's not a crazy idea. I think it's a good idea. It's a safe procedure. I think so. Better than disconnect the ileum and try to preserve the colon, because the patient is already has fecal control. Try to disconnect the small bowel and try to preserve the remaining colon, which is normal, at least histologically is normal, and then do an ileocolon-anastomosis. I think it's not going to improve bowel movements or fecal control, because already the patient has fecal control. And I think it's a major surgery to disconnect the ileum, and the possibility to again produce more damage. I don't know if the patient has already damage, and that's why she has urinary symptoms, will increase this possibility. To me, the safest way is to reduce as much as you can the Duhamel, and try to do now a good Duhamel, which is not indicated in this patient. In other words, as Alberto said, this patient had a Duhamel and it was not indicated. So it was a wrong or no well done Duhamel in a normal patient. what you can do is redo the patient and try to do the best Duhamel that you have done in this patient. Is my my opinion. Thank you.
Thank you. May I ask a question?
Sure.
Dr. Bischoff pointed out something actually that I did not think about, and you highlighted it, is when we talk about a spur in Hirschsprung's disease, we're talking about a non-functional blind ending residual colon that can cause problems. Here, even though this left sigmoid or sigmoid / left colon is blind ending, it's functional. So could it be that it is not a problem? Could it be that there is not a problem with bacterial overgrowth in it? Because even though there's nothing entering it, it still can evacuate mucus. And which is why I like the idea of taking to, because I was planning to take an OR scoper anyway. But maybe putting a colonoscopy and then irrigating that colon, seeing what's in it, maybe there's nothing in it. And then we can say, well, actually, it's not, even though it's blind ending long colon, it's actually not causing problems, and subsequently not even do anything. Because all this time I've been thinking this is a long residual, quote unquote spur, but the reality is this should not act like a spur because it's functional. It should be able to evacuate its own mucus like a long Hartmann pouch.
Yeah, I agree with that. I think scoping and see what's inside, see how much stool there is inside, how much mucus, and you can take the opportunity to clean it while you're there and see how the patient feels. But there is a chance that this is not the cause of her abdominal pain.
Yes, in the contrast study that you show there, if it was my patient, I would request the follow-up of that particular study. How is that after 2 hours, after 3 hours, 6 hours, after 12 hours, to see how well is emptying that colon? That's a functional study. That's why I like to go to the X-ray department with my patients and be with the radiologist, and because the radiologist doesn't know what you are looking for. Obviously, the small bowel is working well. The small bowel doesn't seem particularly dilated. So that means the connection between the small bowel and the rectum is wide open, and you can confirm that endoscopically. But you want to be sure that that colon is emptying very well. And if that colon is emptying very well, then the question is, why is the patient having that abdominal pain, right? And concerning the urinary incontinence, I understand that you described nocturnal enuresis, not urinary incontinence, right? And thus nocturnal enuresis is not necessarily related with if the patient is urinary incontinence during the day, that would be a different implication. And but that's it's a dilemma for this patient. Is not an easy case. It's very unusual. And the question is, where do you get cases like that? Yes.
Where? Our GI team.
The team, the GI.
Yes, I misspoke. She only sleeps in a pull-up because at night she has some nocturnal enuresis. Correct. During the daytime she feels it. She can control it. She has no problem during the daytime. At night only does she need to sleep in a pull-up.
Okay. Okay, I'm not sure we solved your problem, but I think
No, you did. It was excellent. That was great.
Ideas.
That was very good insight. Thank you. No, that was great insight. Thank you.
Perfect. Okay, thank you so much. And now we're going to move to the next case that will be presented by Dr. Alejandro Ruiz from Mexico. So we're just going to switch screens. You can stop sharing, and then Dr. Ruiz will share his case.
No puedo compartir. Es que no se comparte.
We saw your screen and then it
One moment,
disappeared.
please. No, aquí la comparto. Pero no me muestra la presentación para compartir. Excuse me. ¿Se ve? Yep. Thank you.
Perfect.
¿Se ve?
Now it disappeared again. It was
Yes.
there.
Thank you. Excuse me. ¿Se ve?
I think you have to click on the slideshow.
Yeah, you want to click on the full presentation at the very bottom, the little screen coming down.
Es que no me aparece la... Excuse me. I can share the presentation. I don't know why. Ray, you have my presentation?
Yeah, give me a second to pull it up. Hold on.
Yes, thank you.
Andrea, can I have a little opinion about the prior case?
Of course, yes, go ahead.
Using liner cutting green cartridge staplers to expand the Duhamel window and communicate the rectum to the ileum will need a laparoscopic device and use it transanal, something similar to when we communicate an uncystic linear duplication. Thank you.
Let me see if I understood well, Carla. You mean a procedure to make the connection between the small bowel and the rectum wider, am I right? Is that what you, okay. The fact in this particular patient is that is not a stricture. I understood from the presentation that the connection between the small bowel and the colon is wide open and that the small bowel is not dilated. If there is any suspicion of narrowing of the anastomosis between the small bowel and rectum, yes, there's a indication you can do it transrectally or from above, but you make disappear the wall between the anterior rectal and the posterior rectal wall and the anterior terminal wall of the ileum. Yes.
Okay, I think Dr. Ruiz is ready now. Go ahead.
Good morning, everyone. Thank you, Dr. Bishop. I will present a case operated by us 2 months ago in a public hospital. The patient is a 16-year-old male that suffers an anorectal trauma due to a fall from a bicycle. 5 days after the accident, he came to the emergency department. In this picture, you can see the physical examination in the emergency department. In this picture close up, you can see the skin and the anoderm in the right side and the great damage of anal canal with skin and fat tissue necrosis. Well, what do you do in this case? Number 1, antibiotics and delayed surgical reconstruction, colostomy and delayed surgical reconstruction, colostomy and anorectal reconstruction at the same time, surgical reconstruction and no colostomy, or other options. The majority respond colostomy and delayed surgical reconstruction. Okay. We decide perform a colostomy, then in prone position, we irrigate the distal segment through distal mucous fistula. In this picture, in prone position, you can see the anorectal injury. In this picture close up, you can see the damage to anal canal. We resect the necrotic tissue and perform a meticulous reconstruction of anatomy. This picture shows a partial reconstruction of the anatomy. In this picture, we use the Lone Star retractor to show the final aspect of the wound. In this picture, we show the final aspect of the anorectal anatomy. As expected, 2 days after colostomy and anorectal reconstruction, the patient developed wound infection. In this picture, you can see a little descent of the wound. A change in the antibiotic therapy improved the evolution of the wound. 7 days after surgery, the patient presents abdominal pain and vomiting. In this X-ray film, you can see radiological signs of intestinal obstruction with the clinical with the clinical and radiological signs, we perform a laparotomy. We find a related colostomy complication. The descending colon presents 180-degree twist below the abdominal wall. The aponeurosis was tight, and the solid fecal stasis causes the twist. We perform a new proximal stoma. 5 days after laparotomy, the patient presents fever and abdominal pain, and in the ultrasound show an abdominal abscess. I think we have a peritoneal contamination in the laparotomy. A change in the antibiotic therapy improved the evolution of the infection. In this picture, you can see the aspect of perianal area 6 weeks after first surgery. Here, you can see the damage of anal canal. 75% appears damaged. Well, what will be the next step? Number 1, anal dilatations. Number 2, sphincter stimulation. Number 3, distal colostogram seeking for fistulas. Number 4, exploration under anesthesia. Number 5, all above. Number 6, none. Okay, thank you for the answers. What will you do? Colostomy closure, 2, colostomy closure and malone creation. Number 3, permanent colostomy due to the risk of fecal incontinence. Number 4, colostomy closure and bowel management program. Number 5, other plan. Okay. Thank you. It's my case. Thank you.
Okay.
Let me just see if I understood all what you said, Alejandro. I understood that the patient now is asymptomatic, is doing well. In other words, there is no infection. They all healed from below, and the colostomy is working well, and there is no mechanical obstruction. Am I right?
Yeah.
I'm going to repeat, the wound in the anus is completely healed.
Yes.
Yes. The
Yes.
patient has no sepsis, no obstruction.
No.
The patient has no infection. Right?
No infection. The patient.
And the question is what to do next. Well, what I would do is to examine the anus under anesthesia to be absolutely sure that it's completely healed.
Okay.
To be sure that there is no stricture, and to be sure that there are no pockets. In other words, if it is completely healed and nice looking, I will simply close the colostomy. The patients in my personal experience, in several cases that more severe damage than the patient that you presented, the patient with trauma have high potential for bowel control. It's not like the anorectal malformations. I bet that if you close the colostomy, the patient will have bowel control. But remember, I'm assuming that you check the anus, that there is no stricture, that there are no pockets, that everything is healed, there is no inflammation, that you pass your finger comfortable, that the patient doesn't have pain in the anus. And then if there is any question, I would just simply wait until everything is completely healed, and then I simply close the colostomy. No Malone, no bowel management, because the patient will have bowel control. The patient may have constipation because of fear of passing stool, but I bet that the patient will have bowel control. I don't think the damage to this anus is very severe. It's only one side of the anus, and the anal canal is preserved. This patient will have bowel control. And if not, then I pay the dinner with mole in Puebla.
Thank you.
Several witnesses here. Yeah, it is very interesting, but patients with trauma, they have a very different response than our thought process for Hirschsprung, for anorectal malformation. Those patients, they have good motility, and Dr. Peña had several cases and they all have bowel control. So it's really, at the end, it is a good outcome. And then regarding the colostomy complication, I honestly like that you presented, because I feel colostomy is something that many people have complications, but people don't talk about it. So whenever we open a colostomy, and I think stricture is one of the most common problems of colostomies. When we open in a circular fashion. So we open the skin circular, we open subcutaneous circular, we open the muscle and the fascia circular. We have a complete circle. So it's not just a opening and pulling the bowel. We really make a big incision so to avoid stricture. Any other questions from this case? I think there is the other question about repairing the defect right away when the patient presented 5 days after the trauma. One can argue that late, it is expected that there will be infection in the dehiscence, but at the end, I think the patient healed well because of the diversion. Any other questions or comments? Congratulations, I think it's a fascinating case. So the last case that I will present, it's a very simple one, but it's just following our discussion from the last meeting, because in the last meeting, Dr. Alejandro and Dr. Zornosa presented recto-perineal fistulas that were in the opposite spectrum of the one that I'm going to present today. And we discussed when it's okay to treat conservatively a recto-perineal fistula. So today I'm going to show the opposite spectrum. And I think I already gave the answer. Newborn male patient, what is the diagnosis? I hope you all got to see the pictures. This is a recto-perineal, recto-bulbar, imperforate anus without fistula, or I don't know. Everybody can vote. And let's see, most people got it correct. The others were probably not paying attention. So here you can see, this is a tiny, tiny recto-perineal fistula. And the only reason I brought this is to follow from our previous discussion. This is a case that, in my opinion, there is no discussion. This patient needs an operation. There's no way you will be able to dilate this to a normal size anus. So here is the cross-table lateral film, and you can see that the distance from the anal impression is very short, close to none. And here you can see how he presented at the local hospital, very distended, because with this tiny fistula, even to pass gas is difficult. He had a normal sacrum. So here's the lateral view. And here is in the operating room, just to appreciate how tiny this recto-perineal fistula is. And when we operated, we placed multiple 5/0 silk, we started posterior sagittally, and this patient had about 1 centimeter of this narrow fistula that you cannot make an anus here. So it was not just a case of opening. You really have to mobilize, because the normal anus, the normal rectum will be here. So we mobilized, and then we made the anoplasty. So this is just a simple case, but I thought it was interesting to compare with our presentations from last week, that we were discussing that not all recto-perineal fistulas may need surgery. And this one is, I think, a case that it's obvious that the patient needs surgery. So this patient came to me already with a colostomy. He underwent a colostomy during the newborn period, and we did the repair. Any questions? We are on time to end this meeting. And I just would like to thank you all for joining. We had pediatric surgeons from Bangladesh, Ukraine, Egypt, Spain, India, United Kingdom, South Africa, Turkey, Mexico, Thailand, Saudi Arabia, Malaysia, Indonesia, Libya, Cameroon, Colombia, Iraq, Bolivia, Tunisia, Brazil, Sri Lanka, Bahrain, Nigeria, Sudan, Afghanistan, Argentina, Rwanda, Paraguay, Italy, and Germany. I think I mentioned you all. Dominican Republic and Chile.
One word to our brothers and sisters from Ukraine. All of us all over the world are extremely concerned and worried, and we want you to know that we are with you. And I hope very soon the conflict resolves and you go back to a happy, normal life. We love you.
So thank you, everybody. We wish you a good weekend. We hope to see you next month. Bye-bye.